So the Landmark 2 study is a follow-up study, and it's a worldwide health study looking at MPN patients and also physicians and their perspectives. In particular, the abstract that was presented on behalf of a diverse group of authors, of international, including patients, etc., focused in particular about the differences that we saw in the results of this follow-up study in terms of cardiovascular risk assessment in day-to-day practice and the disease-related psychological burden from patients and the mismatch at times between clinicians or physicians and patients. And so just as a kind of to give you an idea of timing and scope, etc., this was a survey that was conducted in 11 countries over a year between April 21 and May 22. So recognizing in terms of psychological burden, etc., it spanned pandemic time. Patients are across the adult age range, aged between 18 and 89. And patients were stratified according to treatments they had, whether on the first line or a second line study or multiple line. And we had over 130 physicians and just over 270 patients who completed the survey. Just to give listeners a heads up in terms of the patients, so they were pretty much as we would expect for these patients. Their median age was in the late 50s to mid 60s, and the time since diagnosis was, according to whether they were on a first therapy or not, between just under a year to over 6 years. And the most common treatments that patients had were hydroxyurea or hydroxycarbamide or ruxolitinib, and very often they were having venesection. So these were patients who were at risk. And just as a reminder to the listeners, that cardiovascular events are a main cause of patient morbidity and mortality in this patient group. So we asked things about how often was a basic cardiovascular assessment defined as blood pressure and cholesterol performed, or something a little bit more comprehensive, EKG or an echocardiogram. So we found that somewhere between a half and 3/4 of patients had a blood pressure or cholesterol routinely performed, but way fewer, down to as few as less than a third of patients had something like an EKG or an echocardiogram. And amongst physicians, some said they never performed these basic tests, perhaps because they were actually performed in the community, for example, but large numbers of them were saying they had insufficient time or insufficient resource. And there's something also about the fact that these kind of assessments, whether they really sit within hematology or hem-onc routine care or not. So the abstract is quite provocative in terms of there's a gap here, who's doing it and who's responsible in terms of cardiovascular risk. And so for us, that's prompting a call to look at, making some standardization and some standardized recommendations. In terms of psychological impact, which was a second half of the abstract, this was really sort of following up. And I was particularly interested to look at, whether there'd been a change and whether there was support for psychological impact. So most patients, 58%, reported an impact that was scored at 3 to 5 on a scale out of 5 of impact on well-being and mental health. And these were in particular patients who were on second line or beyond the first year of therapy. So it's not just at the beginning. And then just in terms of the physician comments here, physicians made a comment that they felt they weren't assessing psychological burden often enough. But interestingly, patients frequently reported feeling satisfied with support. So there's something about talking about it, physicians feeling that they're not supportive enough, but patients actually, at least half of them reporting that they felt supported, sorry. And in terms of the type of support, there was somewhat of a lack of communication on self-help strategies, and then rationale for specific help being missing in terms of, again, the emotional burden. So really kind of rich data in terms of what we're feeling that we're not providing, that we should be, probably quite guilty about it as clinicians in often very strapped services, but also a really interesting reflection from a matched patient population. And sort of summing up, the main gap for me is around standardized methods and frequency of those for monitoring cardiovascular risk, and the findings around that physicians and patients often disagree about the perceived importance of quality of life, and these really tying up these often common themes about communication and regularity, and possibly just reflecting that this is at a time of heightened stress for both parties, the physician and the patient.